So we will now focus on the question whether recovery of kidney function can be affected by the initial renal replacement therapy modality choice. And first of all, you see my conflicts of interest. I received some lecture fees as well as an unrestricted research grant. And before we go deep into the topic, I would like to focus on the current questions. I mean, we already focused on the optimal time point for initiation, but we also have several other questions regarding renal replacement therapy as the type, which we will focus now, the anticoagulation, which we will focus in the next talk, and also the dosing and stopping criteria for renal replacement therapy. Each of these questions actually or each variable may have an impact on patient outcomes. So we will focus on the type of the initial choice of renal replacement therapy. And before we go deep into this topic, I would like to focus a moment on different management practices. And here you have two observational trials. The first one on the left side is the EPIS-AKI study. This was a large observational study among 10,500 patients undergoing extended surgical procedures. And the question was, what is the incidence of acute kidney injury in this specific patient cohort? And we found that every fifth patient developed acute kidney injury within 72 hours after the surgery. On the right side, you see the results of the AKI-EPI study. And in this study, critically ill patients were included, and they found that every second patient in the ICU develops AKI. And here now you can see that in the perioperative setting, among those patients developing AKI, 8.7% of the patients received renal replacement therapy. And when you have a look at the different types of renal replacement therapy, you see that most of the patients received a continuous form, so 74%, whereas 19% received an intermittent hemodialysis and 7% received a prolonged intermittent renal replacement therapy. But none of these patients in this specific patient cohort received a peritoneal dialysis. When you have a look at the ICU cohort, you see that among the patients developing AKI, 23.5% received a form of renal replacement therapy. And the type of renal replacement therapy is similar to the perioperative setting, actually. 75% received as initial choice continuous renal replacement therapy form. 24% received an intermittent hemodialysis, and just 1% received peritoneal dialysis, and none of these patients received a prolonged intermittent form, which may be a result from the fact that this was published approximately 10 years ago, so the observation period was more than 10 years ago. And when we focus a moment on the latest randomized controlled trials that have already been introduced in the last talk, you can see, and this is a bit changed as I see here on the slide, but you can see that in the Lane cohort, 100% of the patients received continuous renal replacement therapy, whereas in all these other multi-center settings, 56% in the AKIKI-1 trial received an intermittent hemodialysis, 50% in the ideal ICU study received intermittent hemodialysis, 30% in the STAR AKI study, and 60% in the AKIKI-2 trial. So there are large practice variations when it comes to what is the initial choice of renal replacement therapy throughout the world. And the question that raises is whether this is important. And before we answer this question, we have to focus on the technique principles. And the first thing, and this has already been introduced in the first talk, we have the continuous therapies on the left side and the intermittent forms on the right side. And during continuous renal replacement therapy, or within this field, we have different modes that can be implemented. We have CVVH, CVVHD, and CVVHDF. And depending on what you choose, you have different principles going behind. So during CVVH, you mainly have the principle of convection, whereas in CVVHD, you mainly have the principle of diffusion. And in CVVHDF, you combine convection as well as diffusion. And in the intermittent therapy forms, you mainly have diffusion. And this also has effects, obviously, on the dialysis flows, which you find here. Where in CVVH, as you do not have any diffusion, you don't have a dialysis flow, but this is obviously different in terms of the intermittent forms. But the next thing that is very different is the blood flow rates. So if you have an intermittent form of renal replacement therapy, you need much higher flow rates as compared to the continuous forms where you have a smoother form of the therapy. And this may have implications for hemodynamics and also for fluid accumulation. And here you can see one study or one meta-analysis that has been performed several years ago. So this was published in 2008. And you can see here that in this secondary analysis of the meta-analysis, you can see that 4 studies were included. And here you see the effects on hemodynamic events. And you can see that there is a beneficial effect favoring continuous renal replacement therapy, where you see less event numbers for hemodynamic instability. And this phenomenon might, on the one side, be a fact from the different blood flow rates you need for the therapy, but also when decreases in intravascular volume resulting from ultrafiltration and or osmotic insults exceed the rate of compensatory plasma refilling from the extravascular compartment. On the next hand, or on the next side, you may have some differences in fluid accumulation, and this is what can be seen here in this nice overview. You can see that here, during continuous renal replacement therapy, you have a more effective therapy on fluid overload with a smooth decline in fluid overload, in the percentage of fluid overload and fluid accumulation, whereas in the intermittent forms, you have a slight increase of fluid accumulation, which means that if you have a patient with fluid accumulation, it seems to be more effective when you use a continuous form of therapy for treating fluid accumulation. And just recently, we created a German guideline for renal replacement therapy in the ICU. And obviously, we performed a literature research for this. And we wanted to know whether there is an effect on mortality detectable. And we found different systematic reviews, 6 of them dealing with the effect on mortality. And you can see here that none of these systematic reviews showed a clear benefit for continuous renal replacement therapy when it comes to the mortality endpoint. You can see that the in-hospital mortality here, the risk ratio was 1.18. So all of these 1.01, sorry, and you can see that all of these studies and the results did not show a clear benefit, so no significant difference in terms of mortality. However, we have all of these large randomized controlled trials that primarily focused on the ideal time point for initiation, but there are secondary analysis available. And you have here first a secondary analysis of the AKIKI and the ideal ICU studies, which were 2 multi-center randomized controlled trials. And you can see here that 543 patients, critically ill patients, were included here in the study. 50.5% were treated with intermittent hemodialysis as first modality choice, and 49.5% with continuous renal replacement therapy. And you can see here that the effect on surviving was better in the hemodialysis group as compared to the red line, which is the continuous renal replacement therapy group. And besides the first analysis, they performed an inverse probability of treatment-weighted sample analysis to look for conflicting results and conflicting variables. And you can see that also in this inverse probability analysis, you can see that there is no clear benefit for intermittent hemodialysis as compared to continuous renal replacement therapy. I mean, the p-value is 0.049. But actually, this is not a clear benefit for intermittent hemodialysis. But the next step and the next thing they performed was to look for the severity of illness. And you can see here 3 groups. So the first group are patients with a SOFA score of 3 to 10. The second group is a SOFA score of 10 to 13. And in the third group, patients were included with an initial SOFA score of 13 to 23. And you can see on the left side, so the patients with lower illness severity that there is a clear benefit for a treatment with intermittent hemodialysis. So the proportion of surviving was significantly better in the group where patients were treated with intermittent hemodialysis first. But this actually changes with higher severity illness. You can see here, SOFA score between 13 and 23, where this changes. So the red line, again, the CRRT patients, and this is not statistically significant, but you see an effect and a better effect on survival in patients treated with a continuous form of renal replacement therapy. So assuming that in higher illness severity, you may have a beneficial impact on mortality if you treat the patients with a continuous form of renal replacement therapy. But overall, I cannot say that there is a clear benefit for continuous renal replacement therapy when it comes to mortality. The next thing that can be questioned is whether the kidneys may have a beneficial effect depending on the initial choice of modality. And this is what we actually want to focus on in the next couple of minutes. And here you can see a very nice overview of an analysis of the Hydenic database, which included 4,700 patients. And in this cohort, approximately 29% of the patients received renal replacement therapy. This was obviously a retrospective analysis, and you can see that patients were treated either with intermittent hemodialysis or with continuous renal replacement therapy. And you can see that when you have a look at the recovery rates, that in the continuous renal replacement therapy group, the renal recovery, the incidence of renal recovery was 75.4%, whereas it was only 66.6% in the intermittent hemodialysis group. This is a significant p-value, so there seems to be a significant benefit with continuous renal replacement therapy in terms of kidney recovery. But what could also be demonstrated is that, especially in the patients treated with continuous renal replacement therapy, these patients had a higher illness severity because at the time point of initiation of renal replacement therapy, the severity of hypotension was significantly higher in the continuous renal replacement therapy group as it was for fluids, for suspected sepsis, vasopressors, and also mechanical ventilation. So resulting from this effects, we may not be able to have a clear argument for continuous renal replacement therapy. But as we know, we have all of these large randomized controlled trials. And as I already said, they performed several secondary analysis also for renal recovery, depending on the choice of initial choice of modality. And here you have a secondary analysis of the START-AKI study. In this cohort, 2,693 critically ill patients were included. And the actual aim of this secondary analysis was to detect regional differences in fluid balance management and also in timing of renal replacement therapy initiation, as well as in the choice of initial modality. And you can see here in the results that we have differences depending on the region where patients were included. So we have three cohorts of patients: the North American cohort, the European cohort, as well as the N6 cohort, so Australia and New Zealand. You can see that in Australia and New Zealand, almost all of the patients, approximately 96% of the patients, were primarily treated with continuous renal replacement therapy, whereas in Europe, this was 56.8%, and in North America 60.8%. And when I saw this, actually, I was struggling with this result because at least in Germany, I know that most of the ICUs use primarily continuous renal replacement therapy. And when we look at the data, we see that this result comes mainly from France, where intermittent hemodialysis is, as first choice, is with 58.9%, significantly higher as those treated with CRRT, and as compared also to the rest of Europe, where intermittent hemodialysis is only used in 11.5% of the patients. And when we have a look at renal replacement therapy dependence at day 90, we see that this is lowest in Australia and New Zealand with 3.2 2%, whereas it is 7.9% in Europe and 10.4% in North America. And when you have a look at RRT-free days at day 90, you can see that in Australia and New Zealand, 82 days as compared to 59 days in Europe and 8.5 days in North America. So there is a significant difference in terms of renal replacement therapy dependence and in terms of renal replacement therapy free days. And the authors also performed a further analysis where the European patients were individualized to the rest of Europe and France. And you can see that there is a significant effect on 90-day mortality. So there are higher mortality rates in patients treated in France, as well as in the combined endpoint death or renal replacement therapy at day 90, and in terms of renal replacement therapy free days at day 90, which were 0 days in France and 73 days in the rest of Europe. When we now look, and this is another endpoint of the secondary analysis on the differences in daily fluid balance, we may assume that one part of these differences in renal recovery may result from differences in daily fluid balance. We learned that that fluid overload is associated with worse outcomes, especially also kidney outcomes. So we see here that there are large differences and practice variations in terms of fluid balance management. You can see that there is a 50% difference between North America and ANZICs, and you can also see that the ANZICs patients and in Australia and New Zealand, the management practices are more in terms of restrictive fluid therapy. So this might be one effect resulting from different management practices. But we also have a further secondary analysis of the START-AKI trial, and this cohort here now includes 2,196 critically ill patients, and the composite outcome of this cohort was death and renal replacement therapy at day 90. And the first thing you see is that in this cohort, 72% of the patients were primarily treated with continuous renal replacement therapy, which is similar actually to the treatment practices that were demonstrated in the APIS-AKI study as well as in the ACI-EPI study. But you can see here the differences in the primary outcomes. So we have a significant effect when it comes to death or renal replacement therapy dependence at 90 days. When you see intermittent hemodialysis, 54.3% as compared to 51.8% in continuous renal replacement therapy. So you see that this is statistically significant, and also the renal replacement therapy dependency at day 90 is significantly higher in those patients treated with intermittent hemodialysis. And they also looked for specific patient cohorts that might especially benefit from a continuous renal replacement therapy in terms of renal recovery, obviously. And you can see here, there is no clear benefit for a specific patient cohort. There is some hint that for a baseline SOFA score in the 3rd quartile, there might be a beneficial effect with better effects on for continuous renal replacement therapy. But here you can see that in the 4th quartile, this is not significant different. So there is no clear specific patient cohort that benefits more or less from a continuous renal replacement therapy or intermittent hemodialysis in the secondary analysis of the STAR-AKI study. Then we have a retrospective analysis, which includes almost 59,000 patients. In this specific patient cohort, 62% of the patients received continuous renal replacement therapy as initial modality. And here, the definition of renal recovery was more than 3 days without renal replacement therapy at hospital discharge. And you can see here that there is a beneficial effect for continuous renal replacement therapy. So this is the cohort of patients recovering kidney function. And you can see that recovery is among 36.9% in the intermittent hemodialysis group, whereas 63.1% in the continuous renal replacement therapy group. So a significant effect on kidney recovery. And then lastly, we have a secondary analysis of the ATN and the renal trials. So just for you to remember, the ATN and the renal trials, these were very large randomized controlled and multi-center randomized controlled trials, primarily dealing with the question of the optimal dose of renal replacement therapy compared to a standard dose. And in this sub-analysis now, the authors investigated the effects of different RRT modalities on renal outcomes. You can see that 85.5% received continuous renal replacement therapy and 14.4% intermittent hemodialysis. And there is a significant effect on renal replacement therapy dependency at day 28. You can see that the odds ratio is 0.54 with a significant p-value. You can also see that this effect can be demonstrated at day 60, but after 60 days, this is statistically not significant. So we have different factors and different studies showing us that there is a beneficial effect on the kidneys. You can see here in the adjusted analysis that there is a benefit. Red is a bad outcome actually for kidney outcomes, and blue are very good outcomes. This is performed in an adjusted analysis, and here the adjusted common odds ratio is 0.45. So that means that we have an improved kidney function in patients treated with continuous renal replacement therapy. So when we question, is there or can recovery of kidney function be affected by the initial RRT modality choice? So yes, there is a benefit for recovery of renal function, but we cannot say this in a very clear fashion because we do not have a large randomized controlled multi-center study showing clearly these effects. All of these effects I demonstrated to you are analysis, retrospective analysis, or secondary analysis of large randomized controlled. So to summarize my talk, we have severe and severe management practices throughout the world. Mostly 75% approximately are treated primarily with continuous renal replacement therapy. We have effects on hemodynamics as well as on fluid accumulation. There is no clear benefit for patient survival, but there seems to be a better effect for renal recovery when it comes to continuous renal replacement therapy.